Yes, I'm 2 minutes, sir.
It's already showing live. Yes.
I'm 2 minutes, sir.
It's already showing live.
I'm
They started on YouTube.
Yeah, it started on YouTube, correct.
Okay.
I sent you the link.
So,
Yeah.
good evening, all. Welcome to the 14th episode of Late Night Retina. Today, we have two very interesting cases on endophthalmitis. One is a chronic endoph, and another is a traumatic endoph. I would introduce the host for today, that is Dr. Remya Paulos. She is a consultant vitro-retina at Little Flower Hospital, Angamali, Kerala. And before giving up to Dr. Remya, I would want to acknowledge Dr. Kushal Agrawal and Dr. Megha Kulati for sending some interesting cases. So over to you, Dr. Remya, if you can start, please.
Thank you, Dr. Abdish. Good evening, everyone. Welcome to yet another interesting episode of Late Night Retina Forum. Today's theme, as you know, is endophthalmitis. Let me introduce our panel for the day. We have Dr. Vivek Dave, who is a consultant. He is my teacher at LV Prasad Eye Institute, Hyderabad. Along with him, we have Dr. Ashish Ahuja, who is working as a consultant at Kamal Eye Institute, Mumbai. And without further delay, let us move on to the first case of the day, which will be presented by Dr. Chintan. Dr. Chintan Dedia. He is a consultant at Sri Ramakrishna Netralaya, Mumbai. Over to you, Chintan.
Am I audible?
Yes, Chintan, you're audible.
Okay, yeah. Good evening, everyone. Thank you, Ashish, Team Late Night Retina and Yossi for this opportunity. So I'll be presenting a case which I had seen when I was a fellow at LVP Hyderabad and posted under Dr. Vivek Dave, who was my consultant at that point of time. So he was the primary treating physician for this patient. So a 51-year-old female presented with chief complaints of diminution of vision in the right eye since 2 weeks. The patient has a history of right eye cataract surgery done elsewhere around 2.5 months before. No other positive history. On examination, the best corrected visual acuity in the right, both the eyes was 20/50. The left eye examination was unremarkable except for grade 3 nuclear sclerosis. And the right eye revealed +2 cells in the AC and the anterior vitreous. This is the slit lamp photo of the right eye. On cursory look, one may mistaken this for an IOL with a PCO, but on close observation, one can see there are some exudates which are present between the IOL and the capsular bag. This is the fundus picture showing hazy view because of vitritis, and disc and third order vessels are visible. So we came to a provisional diagnosis of query right eye chronic post-op endophthalmitis and planned vitreous biopsy plus vitrectomy plus IOL explant plus IOAB for the right eye. So this is the surgical video. This is the IOL, and a standard 3-port pass plana vitrectomy was carried out, 23 gauge. Infusion canal have been secured, and initial conjunctival peritomy was done, and this scleral bed was cauterized. Now a sclerocorneal tunnel is being constructed with the help of a crescent. Visco is injected in the AC, and the IOL is dialed out in the AC. Then the entry is made with the keratome, and the IOL is explanted and plated on the chocolate agar. Now the anterior vitrectomy is being done, and the capsular bag is explanted with the help of the forceps, and the bag is also plated on the chocolate agar. Now the vitrectomy is started. Core vitrectomy is being done. The vitreous was thick, as in the case of an inflamed eye, and complete vitrectomy was carried out. The sclerocorneal wound was sutured and followed by fluid air exchange was carried out. So the vitreous sample was plated on gram, ginseng, chalcopyrrolite stains and subjected to culture, blood agar, chocolate agar, PDA-SD agar for fungi, and the liquid broth, and also was sent for PCR bacterial DNA, fungal DNA, and P. acnes DNA. The IOL and the capsular bag were plated on chocolate agar. So this is the day 1 post-op where the vitreous biopsy didn't reveal any organism on this smear. So the patient was empirically started on fortified cefazolin and Ciplox eye drops, topical cycloplegic, and tablets oral Ciplox. Day 2 post-op, the clinical picture was the same, and there was no growth in culture from vitreous sample and neither from IOL. But the capsular bag grew cream-colored wrinkled colonies on chocolate agar, which on secondary staining on grams revealed oval budding cells with pseudo-IFA. And the report from microbiology interim report was yeast-like organism which was grown, and significance of the growth was yet to be determined. So the topical antibiotics were stopped and topical antifungal netamycin was started. At the same time, LFT and CBC were advised. After 3 days, the vision had dropped to 20 by 320 and the inflammation had increased further. There was no growth in culture from the vitreous sample, or the PCR was also negative, no growth from IOL. But the yeast colonies from chocolate agar from the capsular bag were processed for identification by Vitek2, and the organism revealed was Staphylococcus cepheri, and the growth was determined to be significant. So by this time the LFT and the CBC had come normal reports, and so the tablet systemic ketoconazole was started, and also intravitreal amphotericin B was injected. After 2 days, the inflammation had increased further. We can see the CCCA and the hypopyon here, and the fundus view was very hazy, so a B scan was carried out, which revealed retina attached with membranous echoes which are present. And there was no further growth in the vitreous sample, and the final report from the capsular bag which grew on chocolate agar was Staphylococcus cepheri, the organism with significant growth. So the topical and the systemic antifungals were continued, and also because for the inflammation, topical steroids were started, and susceptibility to topical to antifungal agents was requested. After 2 days, the patient's vision had improved from CFCF to 2200. So one more intravitreal and amphotericin B was repeated. And by this time, after that, the antifungal susceptibility report had come, which revealed sensitivity to netamycin and resistant to amphotericin B, voriconazole, and itraconazole. So when the patient came after 1 week, the vision had improved to 20/50. Even the inflammation was resolving, as seen by the clinical slit lamp photo and the fundus picture. The same treatment was continued. Again, after 1 week, the vision had improved further to 20/40, and the inflammation was also resolving. So at this visit, after 1 week, the steroids were tapered off, and the antifungals were continued, and this topical antifungals were continued, and the systemic antifungals were further stopped. And after 3 weeks, when the patient came, the inflammation had almost resolved. The vision had further stabilized to 20/40, and after in the subsequent visits, SFIL was planned for the patient after 6 months. So after 6 months, when SFIL was planned, this is the day 1 post-op after SFIL being done, when the vision was 20/40 parts. The overall fundus picture is stable, and we can see the SFIL in situ. So routine post-op medications were given, and this is the final visit of the patient, where the vision had finally improved to 20/30, and near vision 6/6 by reduced Snellen's chart, and the fundus and the entry segment were stable. So my questions for the panelists are points of discussion being how to differentiate PCO from capsular bag exudates post cataract surgery, to distinguish between acute and chronic post-op endophthalmitis, to highlight features and management of chronic post-op endophthalmitis, different approaches for chronic post-op endophthalmitis, and should antifungal susceptibility testing be included in routine microbiological evaluation. Thank you.
Thank you, Chintan, for keeping it on time. End up being a difficult clinical scenario, and this case shows a prompt identification of the disease organism and timely intervention, which has resulted in a good outcome. So let's take the questions one by one. So the first question is to Dr. Vivek. Dr. Vivek, sir, retrospectively, when you analyze this case, what are the clinical features that made you feel that this is a case of chronic postoperative endophthalmitis that you're dealing with? And what made you differentiate this from the regular posterior capsular opacification as to after cataract surgery?
Yeah, thank you, Ramya. Am I audible to everyone?
Yes, sir, please.
Yeah. So I think this is an important point about differentiating a PCO capsular bag exudates. The slit lamp photo that Chintan had put up, if one recollects that photograph, one would agree that right at the edge of the iris, the area that you are seeing, which is looking white, actually is a little creamy white. When you look at a posterior capsular opacity, it has a very dull look to it, whereas exudates would have a creamy nature to them. I think Chintan, yeah. If you look at this, you'll see that they are creamy. Now, second thing is little difficult to gauge or judge on a photograph, but when you're looking at this area on a slit lamp, you will again find that these areas are variegated. They look as if some amount of putty-like material has been entangled there between the IOL and the bag. So that is not how a classic PCO would look like. PCO would have a very grayish and dull appearance. So that is one thing that is a big giveaway that this patient possibly has something more than a PCO. And I don't know whether it was mentioned or I may have missed the actual what do you say, symptomatology of the patient that brought her to us was recurrent complaints of uneasiness and discomfort in the eye, for which the patient was getting repeated topical therapy, which was causing a reduction of symptoms, but the symptoms would flare up again once the topical therapy would settle down. So again, a classical history which suggests that something more than a PCO might be lingering there. Yes, Raman.
Yeah. Okay, sir. The next question to Dr. Ashish. When do you call a case as a chronic postoperative endophthalmitis, and what are the usual clinical features that would suggest a chronic endophthalmitis?
Very well presented case, Dr. Chintan. So chronic endophthalmitis we would call usually if the patient is presenting after 6 weeks of a surgical intervention. And what is unique is the type of organisms which cause chronic endoph. Usually we suspect fungal in such cases. And also staph epidermidis can cause Candida propionibacterium acne. So what these fungi have in peculiar features are the cell wall prevents phagocytosis from macrophages. So that is why they cause low-grade persistent inflammation, and they also suppress T cell activation. And also in certain cases where there could be delayed entry in cases of post-RAB, when there is a blebitis, so that will cause a slightly chronic manifestation. And most cases, 90% of the cases are gram positive. If you consider endophthalmitis, and 5 to 6% cases are gram negative endophthalmitis, and 3% are roughly caused by fungal. And so the presentation would be variable. To differentiate, there might be fine keratic precipitates on the back of cornea. Patients will present with recurrent iritis, conjunctival congestion, mild vitreous haze. Multiple times, topical steroids might be given, it resolves and it recurs again. Such cases, we should suspect that there might be a low-grade endoph which is caused by a slightly less virulent organism.
Okay. Yeah, thank you, Ashish. Dr. Vivek, from what I could understand from this case, the way we went through, initially you thought it could be a case of P. acne endophthalmitis. That is, I hope that is the reason why you started initially on antibacterials alone. And later on, when the culture report came as fungal, then you changed the regimen to antifungal. So what is the treatment algorithm that you follow in any case of posterior capsular plaque per se? And there is one question in the panel regarding this. Should IOL explantation be done at first in the surgery itself, or is it with the recurrent inflammation?
Is this directed to me, Ramya?
Yes, sir.
All right. So I think multiple questions there. Can you just quickly ask me what
One
was the
is
first
that,
thing that you?
yeah, one is that initially you started on with the antibacterial treatment,
Oh,
and then you changed on
okay.
to the fungal regimen. And what made you, I mean, what is a usual treatment algorithm in a case of posterior capsular opacification, like a plaque, like in this presentation? And is IOL explantation the first thing to be done at the first sort of surgery?
Right. So I'll start with the first one. The patient was started on antibacterials first because point one, in our experience at LVPI, though classically the organisms talked of for a delayed onset low grade chronic endophthalmitis is a fungus or a propionibacterium, we have seen a good lot of these cases being caused by staph species also. So it should be kept in mind that though those two are the more famous ones, along with the delayed onset end of, you can have the other gamut of organisms. At LVP, still most of us in our practice pattern restrict usage of restrict beginning antifungals only once we have a proof of a fungal etiology, for a basic reason that if you look at overall chemical composition and its effect on retina, there are a lot of histopath studies which in lower animals which suggest that antifungals have a little more toxic potential as compared to your antibacterials. So till the time a proof is there in terms of uh, a culture positivity or non-response or worsening on antibacterials alone, most of us here would tend to start off with antibacterials. So that's the first question. Second, coming to a plaque, I will answer that question with the third question about IOL explantation. Again, I will restrict my opinion to my practice pattern. Over the years, I have seen an algorithmic approach that if you get a delayed onset endophthalmitis, first do a biopsy, doesn't work, inject in the bag, doesn't work, do capsulectomy, doesn't work, then finally go ahead and do an IOL explantation. So in my experience, I have noticed a quicker resolution whenever the IOL is removed. Now, the algorithmic approach in its way may be correct, but I also feel that the decision to stay away from an IOL explantation has a lot of implication with respect to psychology on the side of the treating physician as well as on the side of the patient. If you suggest to a patient that you are going to remove the IOL, or suggest to your referring doctor that the IOL will have to be removed, there is always a shock value there because there is a lot of emotion attached to the intraocular lens. But a lot of our own LVPI data has suggested to us that IOL explantation has a tremendous impact on the overall resolution of a chronic onset, delayed onset endophthalmitis. Uh, I will I will talk to you about our experience in two subsets. One being comparison of cases of delayed onset end of where IOL was explanted as against no explantation. And we've seen that cases where IOL get explanted, they resolve faster, require lesser amount of repeat interventions, and end up with a relatively better visual acuity. Among those cases with IOL explantation, if we look and compare their timeline, those where the IOL got explanted early tend to do better than those that where the IOL got explanted later. So this is our data set. Results may be different in different hands, but what this has taught me is when I see a chronic or a delayed onset end of in front of me, I will initiate, I'm not saying I will explant, but I will initiate the discussion that the IOL will go first things first with the patient at the first visit, so as to prepare the patient mentally. If I get feelers from the patient that he is reciprocating and is understanding the importance of IOL removal, then I am likely to post that patient for IOL explantation upfront. This may be different from how others practice, but this has worked well in my hands. Quickly, one last point. There are studies where um, the explanted IOLs in endophthalmitis have got evaluated, And you will find a lot of photographs of such IOLs in the papers, where you will find that most of the muck, most of the aggregated colonies will be seen on the haptics and on the edge of the optic. So if the organisms are getting sequestered on the haptics and on the edge of the optic preferentially, I don't see how a central capsulectomy with injection of antibiotics will be as effective as removing the entire nidus altogether. So these are the reasons why in my practice I follow explanting IOL earlier than late.
So thank
Yes,
you.
Rama.
Next question to Dr. Ashish. Ashish, mostly these cases of chronic endophthalmitis, they do have anterior chamber findings more than the posterior segment. So, which sample would you like to case in a case of chronic endophthalmitis? Is it the aqueous tap or the vitreous biopsy or both?
Hello. So yes, most cases will have more anterior segment involvement, but usually we can get more amount of sample from the vitreous. I would maybe aim to get samples of both aqueous as well as vitreous and inject antibiotics at the same time. Now, in a delayed endophthalmitis, I would like to withhold use of steroids initially, use of intravitreal steroids. And what we have to know is these the culture positivity rates are, roughly about 60 to 70% only. So in 30% cases, we might not get any growth. And that is for the vitreous tap samples. For the aqueous, the positivity rate is even lesser. And that could also help us to compare both the samples, that if we can isolate the organism in both.
Dr. Vivek, as we know that these organisms tend to remain intolerant in the posterior capsule or the IOL surface, as you were telling us. So is there any surgical step to ensure the posterior capsule has been completely removed? Did you remove it? I've seen in the video, we've seen that, but how do you make sure that the entire capsule has come out? Is there any surgical tip towards it?
Yeah, good question, Ramya. I think the best way to remove the capsule in toto is not attempt removing it, say with a cutter, trying to chop it off would not be a right way, but using a McPherson's forceps, and taking a sort of a broad grip on one segment of the capsule and teasing it out will ensure, because it is elastic in nature, it will ensure that the entire capsule comes out in toto. Once you do it, or at least once you achieve removal of the capsule, one good idea would be to retract the iris, and with small amount of indentation, you will be able to see the pars ciliaris and confirm that the entire capsule is out. Usually, the entire thing will come out together because of the fact that it is pretty elastic.
Okay, so we'll take one question from the chat box. So there is a question on the role of topical and intravitreal steroids in this case, case of fungal endophthalmitis. Dr. Vivek, if you could take the question.
Yeah, so as was mentioned by Dr. Ashish, anterior segment inflammation tends to be prominently present, though low grade, but prominently present in delayed onset endophthalmitis. Often that is what makes the patient uncomfortable and brings to you with symptoms. So topical steroids would have a role to bring the inflammation down, either while you are making a therapeutic diagnosis initially, when you are not sure whether it is an endophthalmitis or not, and you want to give a trial of steroids and see that your topical steroids, so is the inflammation coming up. So it has a role that way therapeutically. And second, once you have intervened, any intervention will also set up its own inflammation. That is again a situation where it would help you. Now, again, in my practice, I have noted that the fact that you have a fungal etiology, even if you pick up a fungal etiology, I have not seen it to be a deterrent to usage of topical steroids. Topical steroids, even in a fungal endophthalmitis, would be of assistance in settling down the inflammation in the anterior chamber. Because as all of you are aware, in any infection in the eye, inflammation is as equal a villain as the infection itself. So if we deal with the fungal part of the endophthalmitis just by antifungals and do not deal concurrently with the inflammation, we might settle down the eye infection wise, but might start losing the eye from the point of view of inflammation and formation of membranes and hypotony in the eye. So in multiple ways, steroids would be important.
Thank you, sir. One last question, Dr. Ashish. Would a resolving all bleed within the capsular bag resemble the exudates of endophthalmitis? What is your take? What is your take on that question?
Sorry, you're asking how to differentiate these
It's a question in the, would a resolving all bleed within the capsular bag resemble exudates of endophthalmitis? How to do, maybe to differentiate, what are the points to differentiate?
No, see, that is old bleed. That is unlikely to, be mixed with these exudates. Now, if you see, it's more probably difficult to differentiate with a PCO in certain cases if, people are not observing closely. So identifying the patterns of posterior capsule opacification, like the pearly pattern or fibrous or diffuse, as to, these exudates will be like clumps in one particular area, and we have to look for other signs of inflammation, look for keratic precipitates back of cornea. Patients will have mild pain, conjunctival congestion. You'll be giving steroids, they'll come back again to you. Now, again, the cause for a bleed would be, something else, surgery related, or I think that should not be a problem too.
Yeah, probably the patient will be having hyphema in the initial post-op setting, or an IOL in the sulcus that would cause a hyphema due to irritation on the iris and then causing bleeding. So that would be a reason.
A dehemoglobinized blood also will be easy to differentiate. I think that should not be a problem.
Okay. One more question to Dr. Vivek. What is the role of silicon oil in or any tamponade in these cases?
Yeah, Ramya. I'm not sure about delayed onset or low-grade endophthalmitis. I personally have not used silicone oil in any of these cases. But there is literature now which suggests that silicone oil, because of its inert nature, does help control the spread of organism, because it replaces the antibiotic cavity by something which is non-nutrient, and thus is sort of an additional weapon to counteract the infection and inflammation. In my practice, I would use silicone oil in organisms which have been shown to be multi-drug resistant on the micro evaluation. Then again, there are practices where silicone oil is used in possibly nearly all endophthalmitis. In RP center where I was training, I think we used to use silicone oil very, very commonly. I think it's more commonly used towards north than towards the southern institutes as far as management is concerned. It does have a very important role, at least in recalcitrant or difficult to manage cases.
Yes, sir. Okay, so due to paucity of time, we'll move on to the next case. So the next case is going to be presented by Dr. Madan Joshi, who is doing his Retina Fellowship at Joshi Eye Institute, Hubli. Over to you, Madan.
Yes, ma'am. Thank you. Am I audible?
Yeah, please go.
Okay. So I'll be presenting a case of 48-year-old man who came from Bagalkot. And he presented to us on the morning of 2nd November at around 10 a.m. He was referred from Bagalkot, a local doctor, for further management. He had alleged history of trauma to the right eye while he was at work when he was doing metal-on-metal activity on the previous evening at around 6:30. So following which he developed diminished vision, severe pain, redness, swelling. It was also associated with headache and vomiting. So on ocular examination, right eye vision was perception of light with PR inaccurate. Ocular movements were restricted in all the gazes. And there was proptosis, chemosis, and AC was shallow, and there was pupillary membrane. So as he was in pain, so limited examination was done. And X-ray orbit was done at the local by the local doctor at Bagalkot, which showed intraocular foreign body. So we went ahead and did a gentle B scan, which showed, you can see here in the left picture, where membranous echoes suggestive of retinal detachment. And also here in the center photograph, there is hyperechoic lesion with back shadowing with the tall spike on A scan. And there is also suggestive of intraocular foreign body. And there is also RC thickening with a prominent T sign, which is also suggestive of panophthalmitis. So we treated him with initial one dose of cefotaxime was given, and Ciplox and Dimox was also given. And under very guarded visual prognosis, we posted under GA, that is a perspinal vitrectomy with IOFB removal with injection amikacin and moxifloxacin plus or minus SOI. So this is a surgical video. Under operating microscope, we could see exudates. So we tried to remove with the cutter, but it was not getting cut. So we had to cut with the scissors, and the defect was sutured. So then we tried to remove the pupillary membrane. We thought we'll go step by step from anterior to posterior. And after doing rexus with infusion in the AC, we tried to remove the lens matter with the help of vitrectomy cutter. And you can also see the orangish glow here, suggestive of intraocular foreign body, which was in the anterior vitreous. And then we inserted the other two ports, but because we could not visualize the ports because of the exudates behind the PC, so we inserted 26 gauge needle. So then we visualized 26 gauge needle, and then we did vitrectomy, careful vitrectomy around the needle, and then we cleared the exudates. At this point of time, we could see that intraocular foreign body dropped posteriorly. And then we cleared the posterior capsule because exudates were adherent to a posterior capsule. And when we entered inside, the view was very hazy. There is vitreous hemorrhage all around, and we could just see intraocular foreign body, and we could not differentiate what was the tissue, whether it was a retina or vitreous. So a gentle vitrectomy was done, and as the limited, there was a limited view, and in that view we could see the necrotic retina. And so the bits and pieces of this friable and necrotic retina was getting aspirated inside the cutter. And so at this point of time, the view became very hazy. So we had to debride the, we had to stop, and we had to clear the remaining vitreous carefully. And the view became very hazy, so we debrided epithelium. And then the view was somewhat better. And here you can see the whole of the retina is necrosed, and there is 360-degree GRT. And the intraocular foreign body is also, you can see. And we injected PFCL, and with the help of there was a necrotic retina all around. With the help of intraocular foreign body forceps, we magnet, sorry, intraocular foreign body magnet, we got the intraocular, we got the foreign body into the AC, and with the help of external magnet, we removed the intraocular foreign body, and we sutured the limbal incision. So foreign body was around 3 to 4 mm. And so as we went inside again, we did PFCL air exchange. Thought we would better leave it alone, and we injected silicone oil and injected amikacin and moxifloxacin. So on post-op day 1, he was symptomatically better, and there was a slight rise in IOP, and cornea was very hazy, so details were not visualized, and ocular movements, there was somewhat slight improvement. And we continued systemic antibiotics and DEXA. So we had given vitreous samples for culture, and we also gave the cassette for for the culture. But on gram stain, there was a gram-negative bacilli, but culture was negative to our surprise. And post-op 1 week, he denies PL, but he was symptomatically better. As you can see here, there is occlusive pupil and labial difference. And so my questions to the panel are clinical features and investigations in panophthalmitis, and whether CT scan is mandatory if you already visualize the intraocular foreign body on X-ray and on B scan, and should we attempt VIA surgery plus IOFP removal in panophthalmitis, and in which panophthalmitis cases to eviscerate, and which ones to attempt VR surgery, and also surgical tips such as port making, vitreous biopsy, vitrectomy, and necrotic retina management. Thank you.
Thank you, Dr. Madan. Nicely presented. So in this case, we'll try to figure out all our doubts or questions regarding the surgical aspect of endophthalmitis management. So first of all, let me ask Dr. Vivek, what are the clinical features of panophthalmitis, and would you consider operating in a patient with panophthalmitis with intraocular foreign body? Over to you, Dr. Vivek.
Thanks, Ramya. Interesting case, and I think very well managed for the type of case that was shown. Again, if you ask me, clinical features of panophthalmitis, I think they are standard clinical features. You have congestion of the eye, you have a look which is endophthalmitis, but the entire orbit looks suffused, looks proptotic, and classically your movements of the eyeball are restricted. So when one has that sort of a picture, that is when panophthalmitis is suspected. And the classic investigation of choice to pick it up is a B scan to show you a subtenon fluid. Mind you, a T sign would be spoken of only when your section is going through the optic nerve. If not, then in any other section, you would be able to see the subtenon fluid. As far as management is concerned, usually the cases of intraocular foreign body which present to you or which develop panophthalmitis while you are treating them tend to be really severe and invariably have a necrotic retina inside. So while this case was astutely managed, these are the cases where it's very important to have a dialogue with the patient and understand what are the patient expectations. If as a surgeon, all of us do want to intervene in such cases, try and retrieve the foreign body, but like I said, a foreign body inside the eye, an endophthalmitis which has gone to panophthalmitis, I would be surprised to see a case where the retina inside is not necrotic. So it should be running in your mind that from a vision point of view, this patient may not get much, and it's likely to auto-eviscerate or likely to slowly go into a phthisis bulbi. If that discussion reveals to you that the patient is not keen from that point of view, once you tell him that the vision is not going to improve, these cases may be better not touched. Because if the surgery does not go out well, you have not really removed the foreign body and given him, this may have repercussions on you as to why did you intervene in the first place. If you have planned to intervene, because panophthalmitis would make the outer coats of the eye little friable, inflamed, and bleeding during surgery on the surface of the eye may be commonplace. It is a good idea to initially have the patient for about 24 to 48 hours on intravitreal antibiotics, systemic antibiotics, and steroids to sort of cool down the eye. And as the eye cools down, you may even have a little better corneal clarity to approach and intervene in the case. So those would be my points, Remy.
Yeah, Dr. Ashish, do you require CT scan? If the patient already has a X-ray with him, do you feel that CT is mandatory in such cases?
Yes, in these cases, we always have the possibility of having multiple intraocular foreign bodies. And the CT scan will give us, about 2 mm cuts, and we can pick up foreign bodies which are, at times get missed with an X-ray. And also B scan would be another useful tool, a gentle B scan, for certain radiolucent foreign bodies like glass.
Yeah. Okay. Since we have the investigations, everything done, and it was showing an panophthalmite picture, as Dr. Vivek right.
Ramya, may I quickly add a point on the
Yeah,
investigation?
sure, sir, please.
Yeah. So most of us are doing B scans. I would understand when we are interpreting or looking for a foreign body. Always remember 2 points about B scans. B scan is an operator dependent investigation. A B scan can rule in a foreign body, but it cannot rule out a foreign body, because you are always dependent on how the B scan has been done by your optometrist, or how well or not well you have done your B scan. A CT scan as against that is very less subjective. So I think if the what do you say, facility is available, a CT scan will give you peace of mind that you have not missed anything. If a B scan has picked it up, well and good. If not, I think a CT scan is a good peace of mind that you have
Yeah, we have always learned from
definitely
you
ruled
regarding
a foreign
CT
body out.
scans, sir, because you used to make it a point that we all do.
I don't touch an IOFB without CT scan.
I know that, sir. And then also in cases of posterior perforation, that becomes very important if you have a
Absolutely.
posterior perforation as well. And
Absolutely.
one more question regarding the practical
There
aspect.
is also a small point. There can be a legality if you find a B scan which is negative and you say that there is no foreign body. You may operate for the retina, things go fine. If later a B scan and a CT scan is done and foreign body is picked up in the orbit, right? You did a good B scan, but you missed out because a foreign body was in the orbit. Then again, it could be held against you that you said that there is no foreign body and now the CT scan is showing a foreign body.
So in short, for medical legal aspect, it is very well to be
In
documented.
today's date, I think it is always that we as doctors take one extra step.
Yes, thank you. Well said, sir. One practical aspect, since the base scan is showing an increased retinochoroidal thickness as well as T sign, what is a surgical tip regarding the port making, Dr. Ashish?
Hello. So yeah, I'll highlight a few points. So firstly, the media would be hazy in these cases. So we could start by scraping the corneal epithelium, and use of AC maintainer would be a good choice. And then we follow the anterior to posterior approach. These cases will usually have membranes in the pupillary area and also maybe in the anterior chamber angles. So with the side port, these membranes should be cleared, followed by a lensectomy, or the membrane should be cleared, and then port insertion should be slightly closer at about 3.5 mm, and once the media is relatively clear, we could use a 6 mm infusion cannulas in such cases once the visualization is better. And also certain surgeons advocate use of antibiotics in the infusion fluid. So the eye is constantly irrigated with antibiotics, and the final concentration which we achieve is much better than injecting antibiotics at the end of surgery. And also followed by intravenous antibiotics 4 to 5 days after surgery. And also important, to discuss use of silicone oil in such cases. In a panophthalmitis case, after removal of intraocular foreign body, see, our primary aim is to achieve a primary globe repair and remove the intraocular foreign body and control the infection. Visual acuity comes almost last in these cases. So it might be a good option to put 5,000 centistokes silicone oil and then close.
Yeah, thank you, Ashish. One more point that I would like to add here is that when you make the ports, you have to go slightly more perpendicular than your angled entry. That would create a more increased depth of penetration further to your trocar cannula. Sir, anything more to add, sir? regarding the port making part? Dr. Vivek?
No, I think Ashish has summarized the points really well.
Okay.
Nothing more on that point from my side. Thanks.
Okay, so there is another question regarding vitrectomy. How far we should go, and do we always do a PVD induction in such cases? Dr. Vivek, please.
Yeah, Ramya, I think I just mentioned in the chat box. So I also used to avoid PVD induction in the early part of my career, but slowly with time, I have realized that uh, unless the retina has patches of retinitis, unless it is looking opalescent, unless it is having patches of vasculitis, it is not really that friable. Uh, all of us who would sort of recollect that when we are operating endophthalmitis, many a times you would have seen hypopure on the slit lamp. When you enter inside, you would see vitritis, but behind that vitritis, the retina would look pristinely clean. So a good chunk of end-off cases actually do not have a direct inflammatory involvement of the retina to a visual extent. I'm saying to a visual extent. If subclinically is present, it's a different thing. But I have found in my hands that when visually speaking, you don't see retinitis or vasculitis, one can induce a slow PVD almost without causing any issue whatsoever. The advantage is that it would ensure that the posterior hyaloid is out. There is no remnant hyaloid remaining to allow proliferation in the post-operative phase, because end of the day, this is an inflamed eye. There will be a risk for proliferation. That much more chance of CME not occurring in the post-operative phase, and better chances of getting a visual outcome in case the eye has potential. So that is how I tend to approach. Any vasculitis or retinitis, I agree, I would not attempt a PVD.
If we are planning for a silicon oil tamponade, is PVD induction a must, or can we do without go without PVD induction?
Again, if you are attempting a tamponade, like we said, why are you attempting a tamponade? There can be two reasons. One is if you feel that you are going to lose the globe, so you want to put in something so that the globe stays. In that situation, whatever amount of vitrectomy you have attempted, you can possibly put in oil and then close. But when you're attempting to use silicone oil from a point of view of utilizing its antibacterial property, it's always advisable to have a PVD induced that will allow you to remove as much vitreous as possible and have that much greater oil fill for a better antibacterial activity. Third usual indication for silicone oil in such cases is an associated detachment, which by principles of detachment surgery, obviously you would induce a PVD. So I think from that point of view, in summary, I would suggest attempting a PVD induction in those cases where you are contemplating silicone oil injection.
And which one would you suggest at 1000 centistock, 1300 or 5000 in such cases?
I would go by what Ashish said. I would also prefer 5,000. These are not eyes you want to intervene repeatedly. So inject 5,000 and sort of attempt to forget about.
Okay, we have one more question in the chat box. Ashish, could you please take the question? What is the step-by-step approach that you would take when the infusion port is not visible because of the thick exudates?
Hello. So yeah, you start with using an AC maintainer and you insert the port, and then with the vitreous cutter, you go inside and clear the exudates near the port area. And using 6 mm infusion cannulas would help. And then insert the port on the other side also, superonasal, superotemporal. Use the cutter on both sides and clear the exudates near the port side. You can put the light pipe also and check. Do all these maneuvers with the help of an AC maintainer. Use the cutter first, then use your light pipe and enter and see if the area is clear of exudates and you are having a view to proceed further, and then you can switch from AC maintainer to an infusion cannula If it's a panophthalmitis case, preferably go for a 6 mm infusion cannula, which is inserted straight. Don't go for an angled entry.
And there are a lot of questions coming in the chat box regarding the ideal method to do a vitreous biopsy and how to plate them. Dr. Vivek, if you could answer the question.
Yes, so two ways of collecting the vitreous sample is known. One is, aspirating with a needle, and second is using a cutter. I think aspirating with a needle as far as possible should be avoided on multiple grounds. One is because of the traction on the vitreous, you may cause an inadvertent break. And second is there is a high chance that if the exudates are thick, you will possibly get a dry aspirate and not really get anything. So as far as vitreous biopsy is concerned, uh, how you take a vitreous biopsy will have different approaches on two different grounds. I'll explain both. The commonest one is what we see in all our routine endophthalmitis. In those situations, if you are planning just a vitreous biopsy, you require two ports. One would be the infusion port. Ensure that the cannula is placed well and you are sure that it's secured in the vitreous cavity by going through the steps that Ashish just mentioned. And then with a cutter to which a 2 cc syringe can be attached, you can get the vitreous sample. As you're collecting the sample and globe goes soft, one can put the infusion on and maintain the pressure again. So that is one thing. A second unique subset of collecting vitreous biopsies is when you see a discrete lesion in the retina and far behind in the retina choroid complex, mostly seen in endogenous cases or seen in infections where the lesion is localized and you actually want to take a diagnostic sample. In those situations, if you take a routine vitreous biopsy from the anterior vitreous, you may not get a good yield. You need to take it from close to the lesion. Now, the problem is if you keep going through the vitreous till you reach close to the lesion, by that time the globe will go soft. So these are the ones where you do something called as taking biopsy under air. So here you put in your infusion cannula, make two standard superior ports, and in the infusion cannula, once you have secured its location in the vitreous cavity, instead of fluid, keep a direct connection with air. Now you can do your vitrectomy. While you're doing vitrectomy and the globe is going soft, it is replaced by air to maintain the entire tone of the eyeball, so it does not dilute your vitreous. Then once you proceed behind and reach your area of interest, that is where you detach connection to the machine and again attach a 2 cc syringe and collect your sample locally. For any of you who are in an institute setting, if you get an opportunity, try and attempt this in your practice, and you will be surprised to see how your yield with respect to organisms will increase when you take a localized biopsy under air. Thanks, Raman.
Yeah. One more question we have in the chat box. There is a frequent chance of phthisis in post-PPV for endophthalmitis. So what are the tips to prevent it? Dr. Ashish, could you please take the question?
Hello. So, this is in respect to intraocular foreign body causing an end off. I'll take that scenario. So what is happening is three things are causing the outcome. One is the direct impact of the foreign body. Second is a secondary infection. And third is a sterile inflammation, which is happening inside the eye. See, it is one thing would be early surgical intervention. Investigate the patient thoroughly. Earlier intervention will lead to slightly better outcome. This will also depend on the virulence of the organism as well. Early intervention will help, and a very aggressive management of the case. Early surgery with a good vitrectomy, injecting antibiotics, sending for culture, keeping patients on IV antibiotics or oral antibiotics. Such systemic management is important if a patient is an uncontrolled diabetic. So the systemic control also will help in getting a better outcome. But it is multifactorial, and just following a systematic approach will help in reducing the incidence of eyes going into phthisis.
Yeah, in my experience, what I've seen is more of pediatric patients going in for phthisis. Dr. Vivek, your experience with that?
I'm sorry. Yeah, phthisis related to endophthalmitis. It's not that it's
Yes.
very common, but yes, there are specific subsets. Like you said, pediatric eyes are likely because of the excessive post-operative inflammation that can come in and cause membranes over the ciliary body. So also, as Ashish mentioned, trauma. So pediatric endophthalmitis and trauma are the two main subsets where such a thing may happen. Otherwise, yes, you may lose visual potential. It is not that endophthalmitis means that the eyes are likely to go into phthisis, largely speaking.
I think an important point to discuss is ways to lower incidence of endophthalmitis, like in post-surgery, So I think povidone iodine has been one strong factor which has been noted to reduce the incidence. Also, there was a very large study conducted by Arvind Eye Hospital where they had used intracameral moxifloxacin in preoperatively and cataract surgeries, and what they found was a 4-fold reduction in cases of endophthalmitis in cases where intracameral antibiotics were used. What are the thoughts of others on this, on ways to reduce endoph?
I think two important points would be preoperative betadine preparation and allowing the betadine to dry and not being in a hurry to actually go to the next step. And interestingly, yes, intracameral moxifloxacin has definitely shown a role. And a small caveat I would like to add here, we have recently gone through our in-house data, two subsets, one where intracameral moxifloxacin was not used and the end of cases that occurred in that subset. Second, where intracameral moxifloxacin was used as prophylaxis and the subset that developed endophthalmitis after that. So it's not that if you use moxi, you will not get endoph, right? You will still get endophthalmitis. But our aim was to compare and see whether they differ in the LVPI setup. So what we found is incidence-wise, once intracameral moxifloxacin was used, the incidence of endoph was lesser than where it was not used. So this is largely known knowledge now. But an interesting thing that we learned is those endophs which occurred post intracameral moxi prophylaxis were milder in their clinical presentation, resolved in lesser number of interventions, and ended up with better final visual acuity. So what did this teach us is, I use moxi as a prophylactic agent. God forbid, if I may still get an endophthalmitis, I am still better off than getting an endoph as compared to what I would have if prophylaxis was not used, right? So, mind you, this is the LVPI setup, but these were all well-controlled cases because we only took cases which were in-house endophthalmitis. So, as Remya would know, in-house in LVPI has a strict protocol by which you manage. So, there is uniformity. So this uniform setup gave us this sort of information. So I think even if you do get an end off, the fact that you used intracameral prophylaxis would still work in your favor from the final visual outcome point of view. Thank you.
Especially in those cases which has a prolonged operating time, and that those cases which has PCR, it is very much preferable to give intracameral antibiotic. That is what the latest ESCRS guidelines also suggest.
Yes.
Okay.
I think PCR, long surgeries, elderly patients, say more than 75 or 80 years, you can have your own criteria. Ocular surface disorders, surgeries, patients where the other eye surgery was eventful. So these situations, I think one can have your own criteria, but definitely you should have a subset in your practice where you would use intracameral prophylaxis as an additional armamentarium.
Yeah. A very good discussion. Thank you, sir. Thank you, Dr. Ashish. So we have come to the end of today's session. Dr. Avnish, do you have any closing comments?
Thank you, Dr. Remya. I would like to thank our panelists and our speakers today for these interesting cases. And thank you, everyone. I think it's above our time, so thank you. And we'll come back soon with another episode of Late Night Retina. Thank you again. Thank you so much.
Thank you. Thank you, everyone. Thank you.
Sir.
Good night.
Good night, sir.
Very nice. Nice present. Nice
Thank
panel.
you.
Nice. So shall I end the meeting for all?